Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you.
Thank you for joining us today on Between Two White Coats. Today we're going to discuss osteoporosis. So,
really
big topic.
Important topic because I don't think anyone talks about it, and I don't think anyone puts value to it.
Well, when I was preparing for this episode, several places, mostly in like the National Institute of Health, like they say that this is the silent disease because it doesn't hurt until it does. And then by the time it hurts, it's a little too late.
Yeah, people will get their osteoporosis and osteoarthritis mixed up sometimes, and they'll talk about, oh, my back hurts or my knees hurt. Maybe I have osteoporosis. And, so in recognizing what is osteoporosis is a decrease of bone density, how strong your bones are, to simplify it. And the way that our bones work is we have two types of cells that are working in opposition to each other. Osteoblasts are constantly building bone. Osteoclasts are constantly remodeling bone or destroying bone. And we need the osteoblasts to do their job well. We know anytime anyone's had a fracture and you just cast it, casts are not magic. All they're doing is keeping things straight. Your body is doing all of the fixing. So keep the bone aligned and the osteoblast will rebuild it, and your bone will fix. And so we have these different kind of restructuring of your bones all the time. When our osteoclasts start to work a little bit more than the osteoblast, when you are tearing down bone more than you're banking it, then you end up with poor bone strength, poor bone density, and then that can be osteoporosis. This typically happens with age. We know that kids can heal, kids can be in a cast for 4 weeks and they have an entirely healed bone. Older people have to be in a cast for,
forever, 6 months.
Yeah. And it's like, oh, it's still not healed yet. It's still not healed yet. And so we just build bone better in youth. It's really age 50 that we believe is kind of our mark for when osteoporosis will start to hit us, where our bone isn't building quite as fast as it might be breaking down. And so that kind of comes to, who should be screened or looked at for osteoporosis and how do we go about making this diagnosis. And I feel like this is where in healthcare we fail a little bit. One of our nurse practitioners, Scotty, and I decided a year or so ago that we didn't feel like we were doing a good enough job in general, in primary care in general, and us, period, in addressing and treating osteoporosis. We just didn't think we had the comfort level on it that we should have. It's not something that we received a lot of training on. It's not something either, lots of times when you don't receive a lot of training on something, then you can, in primary care, defer to the specialist who did. So I received plenty of training in musculoskeletal stuff. It's not that interesting to me. I don't find great excitement in it. And so if someone has musculoskeletal, I'm a lot quicker to send them to the orthos than Dr. Delp and Dr. Kirkland in our practice, because they have great interest in it. But I love diabetes, and I will function like I'm an endocrinologist some days. I'm like, we can do this. We're going to get this A1C down. And that's what I read about at night. And you can't read about everything at night. And so we have our different areas that we're more experts on. We recently talked about some hormone replacement stuff, and Amber has a lot of interest in that. And so in our practice, we'll kind of refer like, okay, this might be, something related to hormones. I want you to talk to Amber about it because this is more an area that she's gained expertise in. And so we didn't feel like we had the expertise in osteoporosis, but then the problem is, who does? Like, what is the specialist that covers osteoporosis? Ask 5 primary cares and you might get 5 different answers, and ask some specialists and they might say primary care.
Yeah.
And so there is no one for us to turf this to when we don't want to do it. It's us. So we have to have our knowledge in this. So Scotty and I started going through a program that we're really excited about that's through what used to be called the Osteoporosis Foundation, and now they've changed their name to the Bone Health and Osteoporosis Foundation. And they have a program, and it is the Fracture Liaison program, and so it's many hours of learning a lot about osteoporosis, the proper identifying and treating and making sure we're managing it well. And we looked at each other the other day and we were like, holy cow, there was so much that I had to learn on osteoporosis. So I think it's important that we all kind of dig into this a little bit, because we don't talk about it much. It's really ignored, but it's a big deal when we ignore it. What's the outcome of untreated osteoporosis? Fractures.
Death.
Yes. And so when we say break your hip and die, people think that's crazy.
Yeah, well, I mean, this is like super fresh, very, very fresh for my family. But my grandfather fell and broke his back in the beginning of August, and he died September 3rd. Because he had complications from the fracture. He was an 85-year-old male with osteoporosis, most likely. I don't know that he ever had a DEXA scan, and just other complications because he was an 85-year-old man.
Yeah.
And men get osteoporosis too. So I think a lot of times that's a myth. We always think about women, but men also get, and their mortality rate actually is higher than females if they have a fracture. And so my grandfather is now a statistic, truly. And that's crazy.
So unfortunate, but the statistics on falls in over 65-year-olds is astronomical. And I hope that this stands out, and I hope it's something that people will memorize and repeat, because we have to prevent falls. We have to identify osteoporosis because the outcomes are remarkably bad. It is 20 to 25% of people age over 65 who have a fracture will die within the next 1 year.
Yeah.
We are talking 1 in 4 people who have a fall over age 65 and fracture something, or have a fracture over age 65, will die within the next 1 year. Now, if that was related to anything else, we would be talking about it. Somehow we're not talking about this. It is another 30% of people who have a fracture who will lose their independence. So we are talking about you cannot go back home, you cannot live independently, you might be in a skilled nursing facility after this because of a fracture. So half the people who fracture over age 65 will dramatically change the course of their life because of that fracture. And then we have 80% of people who have a fracture over 80% will lose the ability to do at least one activity of daily living. So when we want to age healthy and we want to be able to live our best life into our 80s, 90s, we have to be able to sustain all of our activities of daily living. We have to cook for ourselves and get dressed and be able to keep our house, to be able to stay home safely. And one fracture changes that immensely. If you have a fracture, the risk of a second fracture within the next year is extremely high.
Yeah, that's what I was about to say. Like, if you have one fracture, then the likelihood of having another one is crazy high.
So the first question out of all of our mouths, whether it is a friend, family member, or us, the doctors, when we are seeing a person who is over age 50 who has had a fragility fracture. Fragility fracture sounds like the little tiny lady who's 90 and you look at her and go, you have osteoporosis. You're 4 feet tall and your back is completely hunched over. But a fragility fracture is really just defined as if you break something from a fall without a height. So if you are standing and fall, if you are, more or less at floor level and fall, if you fall off a house, that's a different story. But if you are standing and fall and something breaks, the most common breaks are for osteoporosis related are hips, spine, and wrist. And we will frequently discount that wrist because we think, well, you fell on an outstretched hand. Anyone would have broke their wrist. But if you fall and you're just standing on an outstretched hand and you break, then you need a DEXA. So everyone needs to say, so if grandma and grandpa broke something, if your mom tripped and broke something, the very first thing we need to say is, have you been tested and worked up for osteoporosis?
Yeah. And even prior to my grandfather, but I've always been somewhat aggressive about this because I know, again, we've talked about us seeing a bigger picture, and I'm like, if this has happened, because of the risk, because of the statistics, I'm more likely to say, hey, I don't know if your insurance is going to cover this, but I'm going to need you to have this scan.
Yeah. To the point of, we in our clinic have purchased a bone density scanner so that we can make affordable DEXA scans, because unfortunately we're not being very aggressive about the prevention of this. And I believe that people need to be able to talk about their bone density age 50 and over, like they were talking about their cholesterol, like they were talking about their sugar. They need to know,
or a
what
mammogram,
this
or a
is.
colonoscopy. Like, these are screenings that we can offer
Yes.
that can save lives.
That can save lives and save quality of life. And isn't that really the bottom line of what we're trying to do? And so, unfortunately, there's not great recommendations, which gives insurance a lot of leeway for what they will or won't pay for. The United States Preventive Task Force recommends a DEXA bone density scan to look at the strength of your bones in women over age 65.
Which makes me want to pull my hair out.
Pull my hair out. And when the United States Preventive Task Force recommends something, it will typically make insurance companies have to follow that recommendation to pay for it. And so age 50 to 65 in a woman, we don't get to know your bone density, but we know that it is a straight drop off of your bone density when you are perimenopausal.
Well, that's what I will say. Like, estrogen drops so significantly, and we know estrogen is bone protective.
Yes.
And then everybody's scared of hormones because
so when
of
your
the other
estrogen
thing.
jumps off the cliff at age 50, your bone density went with it.
Yeah.
And so many times it is really that perimenopausal for women that we can save some of your bone density. And we're in that window, that perimenopausal window is when we might say, hey, estrogen, we're on the fence. You're having some symptoms, but you're not sure whether you want to do hormones. They're safe for you. Do we do them or not? I would love to get a bone density and see if you are already osteopenia, which we're going to define these phrases. But if your bone density is a little bit below normal, but not meeting the criteria of osteoporosis yet, and you're perimenopausal and we're wondering about estrogen,
I'm giving you some.
that's a definitive decision for me. And if I was the patient and I saw I can protect my bone density and not have osteoporosis when I'm 80 if I take these hormones for a few years and protect my estrogen, that's when we really want to be bone protective. But we're missing that window because we can't get bone densities paid for. So we would like to make bone densities affordable to people so that we can get them more often. What we're typically finding is women over 65, we recommend a bone density. There's some clear recommendations.
Often already have osteoporosis.
We never, just like you said about, and
it's too late.
And maybe have already had fractures.
Yeah.
And we are almost never getting them on men.
Yeah.
We don't know, like, what is the recommendation for when do we check a bone density on men? And we're missing that window of over 50 because the risk goes up over 50, but we're not starting to look at it until 65. We've missed a lot of opportunity there. Yeah. So to diagnose osteoporosis, if you are over 50 and have had a fracture, a non-traumatic fracture, then you need to be talking to someone about whether you have osteoporosis.
And there's also, I take into consideration, I know you do as well in practice, but like if you've had to be on steroids for any length of time, or if you have an autoimmune disease, or if you've had chemotherapy, all of those also increase your risk.
Absolutely.
And so,
lots of medicines that can increase your risk, particularly steroids, not just oral steroids, but also inhaled steroids. So if you
had
are
asthma,
a kid who's had asthma since 20, then I want to get a bone density on you at 40. Because if you've had to do inhaled steroids every day, then that's had an effect on your bone health. No one will question whether that's had an effect on your bone health. How much effect is what we need to know and be preventive. So absolutely, glucocorticoid steroids, prednisone, those type inhaled steroids for respiratory diseases, pulmonary diseases.
Yeah. Family history, that also is a huge one. If you have a family history
is a big one. The specific question that is used in the FRAX calculator, which I'll talk about, is whether you have a family history of a fracture. You know, you might not know that you have a family history of osteoporosis because we haven't done a great job of identifying it. So if you have a family history of a fracture, then that you want to use as recognizing that if you had someone over 50 with fracture, then that's an increased risk.
People underweight, like so people who are just naturally thin or have struggles with eating disorders, like someone who's, we say quote unquote failure to thrive, but their BMI is less than 20. That is someone at 50. Like I have a friend whose BMI is like 18 and she's always been petite. And I was like, hey, we probably need to get a bone density. And she's osteoporotic.
We don't want to wait till she's 65.
And she's already osteoporotic at 51.
Yeah.
But she's thin. She's always been thin.
Yeah.
And so,
and Asian and Caucasian is two ethnicities that have an increased risk of osteoporosis. Also, if you have a malabsorptive disease, so it could be that you're not eating enough calcium, vitamin D. If you aren't absorbing it. So if you have celiac disease, if you have, if you have other malabsorptives like inflammatory bowel or
Crohn's, ulcerative colitis.
Yes. If you have issues with vitamin D deficiency, and a lot of people do, vitamin D helps take the calcium out of the blood and put it into the bone so that we can build bone, so that those osteoblasts can do their job. And if you have a vitamin D deficiency, then you may not have this. So if you've been getting supplemented with vitamin D by your doctor since age 30, then we don't want to wait till 65 to screen you for osteoporosis. We want to do that more at 50.
Yeah.
So many things would even make us say we want to screen someone for osteoporosis prior to age 50. So let's talk about two things. Let's talk about the DEXA and let's talk about the FRAX calculator. This is how we start making this diagnosis from a clinical standpoint. First, the DEXA. DEXA is a very low radiation X-ray, more or less.
Yeah, I was looking because I was like, can I say the word for the A? The absorptiometry. I can't
Is
say
that what it is?
It's a dual energy X-ray absorptiometry. I was like, it's this why we call it a DEXA, but I wanted to say it because I thought it was hilarious. I was like, oh, I'm definitely going to screw that up.
I've never even asked myself what this stands for, so you did better than me.
I was like, there's no way that I'm going to be able to do it. But it is, like you said, it's a low-level X-ray. It takes
Such
about
a low level that they don't even require you to have lead-lined walls when you have a DEXA machine. It is that little of it is. It is about a tenth, like a 0.1 of what certain X-rays, plain film X-rays are. It doesn't touch CT scans as far as how much. So don't be concerned if you are getting a DEXA every year to monitor. Don't be concerned about how much radiation you're getting from that. It is a minimal amount. And so what it does then is it looks at the lumbar spine and the hips, bilateral hips, for how thick your bone cortex is.
And the test itself it's typically less than 30 minutes. So like, it's not like you're spending all day.
It's not in a big tube like an MRI, nothing like that. It feels like an X-ray. You don't really know that anything's happening. It's not painful. It's not invasive. And it's very quick. It is important when you're getting a DEXA scan that you have a good technician because the validity of that test is dependent on how you're sitting and the machine itself. But then we're going to use that to come up with a one of two scores, a Z score and a T score. The Z score is kind of comparative for age. And that is what we use for people who are 49 and under. So we need to look at Z scores to make this diagnosis in people who are not 50 yet. And then from 50 and up, we use the more traditional when we talk about DEXA scans or bone density scans, and we talk about the T score. And the T score is a very statistical. This is an equation. You plug a number of things into. And if you are down to -1, then from 0 to -1 is considered osteopenia. Osteopenia means reduced bone density, but not meeting the criteria of osteoporosis. This is something that we want to catch and we want to do something with because when we catch it here, we prevent osteoporosis and we prevent fractures. And then when we are at the, from the -1 to -2.5 is the osteopenia. -1 to -2.5. -2.5 and more negative, and less, is osteoporosis. And so it is those T scores that we will base things on. If a person has a T score of less than -2.5, then they meet the criteria of osteoporosis. That of itself meets the diagnosis. If the person has a range of osteopenia, -1 to -2.5, then we look at their FRAX calculator. The FRAX calculator, you could Google right now, FRAX calculator, and it'll come up. And you put the different questions, answers to the questions in there that include things like age and gender and some of the comorbidities that Amber mentioned, like your use of steroids or other diagnosis, family history. So there's a number of different risk factors that the FRAX calculator takes into account, your height and your weight. And when you answer all those questions, then it's going to come up with a risk profile for you. And if your FRAX calculator is greater than 3% risk, you get two numbers out of the FRAX calculator: your risk of a hip fracture and your risk of any other fracture or any fracture. If you are in the osteopenia range and your risk of a hip fracture is greater than 3%, then you can fall into the criteria of osteoporosis. And if you in the FRAX calculator have a greater than 20% in the osteopenia for any fracture, then you can fall into osteoporosis. So there are times when a person doesn't meet the criteria on their DEXA of osteoporosis, but we have to look at the osteopenia as a whole picture. And based on your other risks, should we start treating you? Should we start being more aggressive about making sure that you don't get a fracture? And so I believe that really women over age 50 need to get a bone density, whether we're getting it as a baseline to recognize where we're at, whether we're getting it to recognize what we want to do in treating in the perimenopausal state with estrogen or not. But I think women over 50 and I think men over 60 need to get a baseline. Men have less osteoporosis, but they have it. If you've met a man over 65 who's had a fracture, it is likely osteoporosis, especially a non-traumatic fracture. So we need to be doing a better job of identifying this.
I sometimes get a little, and I don't know if it's just because it's not so more or as common, but like when I talk about medications or treatment options, I get a little bit of pushback from patients. I think they're scared often because it's just not as well known. So it's a lot of education for patients as well.
Yes.
To take into consideration. And there's actually becoming more and more treatments available, which I'm so thankful for.
And there are a lot of classes of drugs that can be used. The common ones are bisphosphonates, which is Fosamax, alendronate, Actonel. There's a number of different medications in this class. The most common side effect from this is stomach upset. They're not really easy to digest. When you take these medicines, you want to sit up for a half an hour afterwards so that it can kind of move its way down.
And they're once a week.
And they're once a week. And you want to drink an entire glass of water when you take it. Kind of help move it through your digestive tract. But if you can't tolerate the oral, then there is also a once a year IV form of a bisphosphonate that may be right for you as well. And then there are many other classes of drugs that can be used too. So if you're in this area, I want you to be more scared of a fracture than you are scared of treating osteoporosis. And then work with your healthcare provider to come up with a treatment that you're comfortable with. The treatment plans for osteoporosis are very comprehensive. We need your calcium and D to be correct. We need you to be doing weight-bearing exercises.
Resistance training as well.
Resistance training, strength training.
Stretching.
Really working with weights is important. And stretching and keeping your bones strong through how you use them. And really considering whether using medications is right for you.
Also decreasing fall risk. Like, I'll tell patients sometimes, like, what's in your house? Like, do we have a lot of rugs? What are we doing in the bathroom? A lot of falls happen in the bathroom. So, like, even those types of things, like when you're sitting with your healthcare provider, like, it is a comprehensive. Like, it is not like, oh, here's a Fosamax and good luck.
Yes.
We'll do this in a year. Like, there's lots of conversation.
You can do with a family member that is over 65 and you're concerned about how well they're getting around is the get up and go test. And that is get up, walk 3 meters, turn around, come back. You should be able to do that in 12 seconds. And if you can't, then you have failed the get up and go test, and you should take that person to their doctor and say they're not getting around very well, because if they're losing their strength, their ability to get out of chairs, most falls happen around the house, rushing to the bathroom at night because of urinary incontinence, things of that sort. And so a full fall prevention needs to be part of this entire plan.
So it's not like, oh, here's this, go do this test, and then we'll treat it. It is truly a medical plan, a team of people that are helping you make good decisions about your osteoporosis.
And if you would like to know your bone density, if you're over 50 and this is not something that's been offered, then and I will say I have under offered this because of availability to it, because of insurance coverage. There are a number of places, ourselves included, that offer cash bone density test, and they are fairly affordable. We're trying to keep ours at a very affordable $100 or less. Other places are anywhere from like $100 to $300 for a bone density test. It may be worth it to get this evaluated. You can call around. Lots of times imaging centers will have a cash discount. So if you're paying out of pocket and they're not running it to insurance, they'll give you a discount on it. But I would say know your numbers, and one of those numbers should be your bone density. If you are 50 and over, you might want to consider, do you know your bone density? Or pull up that Frax calculator and put in the answers to the questions and see where you fall on risk.
Yeah. And the one thing too, which this has nothing to do with osteoporosis, so I'm going rogue here, but you can also look at muscle mass. And so ours here at our clinic, for us that are wanting to do strength training that may not even be 50 yet, but like you want to kind of see, so that's also something that DEXA scans offer that we will be able to offer here, which I'm excited about as well. So it'll help with some of our other programs.
Bone density machines, DEXA machines, can give you percent body fat. It is the gold standard for recognizing percent body fat to be the most accurate. Percent muscle. So as we age, we greatly increase risk of fall. So you didn't go entirely rogue.
I know.
I
was like, I'm really excited about that offering
we greatly
too.
Increase risk of falls with sarcopenia. When you lose muscle, you aren't as stable and the falls go up. So knowing your muscle mass helps you to recognize whether you need to.
And we'll be able to offer
exercise.
that. Yeah, we'll be able to offer that service as well with our DEXA machine. So not only will we be able to screen for osteopenia, osteoporosis, but also to give you guys just the body muscle mass numbers as well.
If you are over 50,
just curious,
I recommend that you know these numbers. If you love someone who is over 50, make sure you are talking to them about osteoporosis. We like to leave you on a good note. So today's Tell Me Something Good comes from Vanessa, one of our incredible employees. Vanessa, tell me something good.
So my husband is having a milestone birthday coming up. He will be 50 on Sunday, and actually we are going to go watch his favorite Georgia football play on Saturday.
That is awesome. So I think something good is celebrating people we love. That's fabulous. Thank you so much for joining us, and until next time, take care of yourself.